primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever so relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Maryal Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care. Dr. Jonathan Bushman is a 2010 graduate of Oklahoma State University College of Osteopathic Medicine and a board-certified family physician, and he practices in Enid, Oklahoma. As a physician and Health Rosetta certified benefits advisor, he emphasizes patient-centered care and modern solutions. His dedication to advancing healthcare is evident in roles like past president of the Oklahoma Osteopathic Association and chairman of the Oklahoma Healthcare Workforce Training Commission. He promotes the direct primary care model, enhancing patient-physician relationships for better health outcomes and cost savings. By advocating for technology integration and education, he drives efficient care delivery. His passion is to propel healthcare innovation towards patient-centered quality care for all. Thank you so much for tuning in today. Find out more about DPC, including resources, discounts, my favorite tech tools, books, and more at mydpcstory.com. The mapper has been updated so you can look for practices by specialty. Follow us on your social media platforms at our handle, My DPC Story, and be sure to subscribe to our newsletter and, of course, the podcast itself so you won't miss out when the next episode drops. So with that, let me welcome our guest. Welcome to the podcast, Dr. Bushman.
Thank you. Thank you for having me.
I do not think that we have had another Oklahoman on the podcast before, so you are officially the first. And this is going to be a great talk. We are going to be talking about not only your practice, but where your practice has flourished in terms of adding additional clinics, adding multiple staff, as well as your role as a physician and an advisor. So again, welcome. And with that, let's hear about what happened before you jumped into DPC.
Sure. I was like many of our colleagues, I worked for a health system. And in many ways, the health system did great things for me. For one, it provided me a residency education, relationships with my colleagues, tons of great experiences. And more than that, it gave me the experiences that unfortunately, for them anyway, led to my passions for DPCs. Every time that we were met with a resistance on trying to enhance patient care or to enhance our practices or just to be fair or just with patients, I realized that, and I'm sure you've heard this from many of our colleagues as well, that cognitive dissonance of who am I going to choose right now? Do I choose my patient? Do I choose my bill payer? Right? The one who puts money in my bank. And it's really hard. I struggled, particularly for the last 2 or 3 years of my employment. I really struggled with these ideas that who's at fault, so to speak, right? Is it the system? Is it the health system? So is it insurance? Is it government? Is it our hospital system? Is it my particular practice manager? And so trying to identify where is this coming from? And ultimately, at the end of the day, when I finally looked at and felt tangibly what DPC was, took me 4 hours in a DPC clinic to see everything. I'm just all right, this isn't whether I'm going to do it. It's how and when am I going to do this? When I saw that, one of the greatest things is that I looked at it, and rather than trying to be anti-hospital or anti-insurance or anti-this, anti-that, I really took the stance of saying I'm pro-patient. And there is one very specific way that I can be pro-patient, and that's to get closer to them. How do I do that? Obviously, to you and me and anyone listening, direct care does that. It literally puts that relationship, and granted, that's the financial focus of it, is that direct relationship, but it's more than that. It also means, hey, all those other factors that we were considering that might get in the way of us just doing what's best for you, we've eliminated those. And it's not that they're all bad players or bad actors, but we've actually taken that influence away from our conversations and that influence away from our decision making. And to me, that's the most liberating experience that every one of us have felt, to get out of the fee-for-service system.
Absolutely. And in the intro to this podcast, I say that DPC is an innovative alternative path to insurance-driven healthcare. But literally what you just said, that is exactly what doctors and patients have always had. And then other players have come into this in terms of, especially in American healthcare, that have come between the doctor and the patient direct relationship. And so I think that this is where, there are people who say in our movement that it's not even revolutionary, innovative medicine. Like literally, this is old school medicine. We innovate because we do things like add tech. You're a big fan of, and I'm a big fan of too. But I think that it literally is so easy for people to adopt this model because it is so simple at the end of the day. It's you're my patient and you need what care? Because you're homebound, because you're a newborn, because you have anxiety. What is the issue going on? I am trained as a doctor, and so are you, and so are all of us who are physicians to be able to adjust to the needs of our patients. That's exactly what we went to not only medical school for, there's a lot of anatomy, physiology there, but to residency. And that is what, I definitely encourage people to not forget, especially those people who are like, but I haven't had a fee-for-service job, or I've only been in fee-for-service for a couple of years. I don't know if I could do it on my own. You learn a ton of stuff in terms of what is normal, and you are able to be a doctor even by the time you hit residency to talk to patients. So I love how simple and easily adaptable this model is to any person who's a physician. So with that, I want to ask about this idea of you thinking about, like, is it the insurance? Is it the government? Is it the hospital? Did you ever feel at any point, or were you made to feel by anybody in your ecosystem at the time, that you could have been the problem? Your way of practicing, like the way that you were efficient or inefficient, had any impact on what came between you and your patient when you were in fee-for-service?
So yeah, actually, it's funny you asked me this because I literally just shared this story earlier today in a similar conversation. But about 7 or 8 years ago, while I was still employed, I hit the peak of my burnout. And just to be clear, burnout to me is simply emotional exhaustion. It's not unique to medicine, but it's definitely prevalent in medicine. Many of us found our way into DPC as an alternative to the burnout. This was a solution to our burnout. But in the midst of that burnout, my health system had actually partnered with or collaborated with Mayo Clinic for some resilience/burnout training and also some research. And part of the research was download this app, create an account, and you're going to get a reminder every month to fill out the survey. And we're going to see if your resilience and we're going to see if this improves over time. And I'll be honest, like looking back, like I was offended by it. I was truly offended by that. I did it, I participated in it. And to be honest, my numbers went up, but my burnout didn't change. It was the reason it felt insulting is it's okay, I'm working for a broken system. The rules haven't changed at all. And you're telling me that I'm the one that needs to enhance my resilience. And it was, yeah, it's somewhat demoralizing. But I will say, just from a very personal standpoint, at the same time, I was going through a lot in my life beyond just the practice of medicine, and just a lot of stressors in life. So there was reason for emotional burnout beyond just the job. And that's not unique to me. A lot of us go through that. And at the time, I was really digging deep. I was reading, I was engaging, I was going through even counseling, just, hey, I don't expect someone else to fix this for me. While I may have not created all the problems that lie in front of me, I'm going to take the responsibility to fix those that I can. And I'm not sure if you're familiar with acceptance and commitment therapy, but that's like kind of the new wave of behavioral psychology. And I've adapted that philosophy. It's like the serenity prayer of, I'm going to accept the things that I can't change, and I'm going to commit to those things that I can. And so that's what acceptance commitment therapy is. And it really helped me through those times. But even now, I look around, and to be honest, you've already mentioned a few of the hats that I wear. There's a lot of potential triggers to that emotional exhaustion again, or burnout. And when I feel it at any point, whether it's just a day or a week at a time where I feel that, I'm very quick to recognize it. I'm very quick to understand where it's coming from. And I now have the skills to adapt or refocus and say, okay, this is where I'm gonna put my energies. To their credit, they were attempting as a health system to help me. And it's what you put into it. I chose to allow it to make me rather than break me. That was just my attitude on it.
It's that is so much more of a testimony to your resilience versus an app telling you what is your score. Because yes, I love tech, I love what it can do, but I do believe that we will never be replaced as human beings because the tech is learning off of stuff that we have done over time, over history as human beings. And so I think that using tools to support what we're doing, amen, it is amazing the things that we can do because we have the autonomy to do stuff. But I think you really hit it on the head that no matter where you are, if you're in fee for service or if you're in DPC, there is always life going on, no matter what job
Mhm.
you are in. And it is always important to take care of yourself because if you cannot take care of yourself, you cannot take care of others. That is a very, again, it's like an obvious thing to say, just like how DPC is so obviously simple, but it's hard sometimes as doctors when we're going into this profession to take care of others. There's a lot of selflessness going into the definition of our profession. And it's sometimes like a huge call out to be like, I am not taking care of myself. Like, how did it get this far? And I think that's where hearing your words, especially because you've grown just in terms of number of clinics, it's freaking amazing while still being at baseline a learner from your own experience and also continuing to be a learner so that you don't go down pathways that you don't want to in the future.
Yeah. It's interesting too that most of the conversations around burnout, particularly in medicine, but even in general, have to do with the treatment of burnout. Like, how do you recover from it? What do you do? And then there's also like the fallout of burnout. So whether that's a divorce or loss of a job or loss of who knows what, right? Even just relationships in general, like there's so much after effect of burnout. And so much of the focus is on treatment. And really where we should be, just like we are in primary care, focusing a lot more on prevention, screening, prevention, discussion. That's where our focus as physicians and colleagues should be. Whereas, hey, I'm recognizing this in you as a colleague, and I'm going to call you out on it and make sure that you have the support and we can do what we can. It's great that you quit smoking after your bypass surgery, but guess what? You have coronary artery disease and you had a bypass surgery, right? Thank goodness you stopped smoking. But you see what I'm saying? I don't want, as one medical student told me, he said, I know 100% that I want to do DPC after residency, but I expect I'll take a 3 or 4 year deal with a hospital just to get some experience before I do this. And I said, so what you're telling me is you want to experience burnout personally? That's what I heard him say. And I literally called him out. I was like, so you think you need the personal experience of burnout in order to get to where you want to go? And I'm like, I don't know if that's the right. I get that in some ways. Like they feel like, oh, I gotta have this experience, but why do you need to put yourself through that? I wouldn't tell somebody you should go through a divorce because there's a lot of personal growth if you choose to do that. Or you should get fired somehow because you never know how much of your life could change for the better. No, that's not good advice. Could it happen? Yes, but that's not good advice.
Yeah. And it's not residency. You don't have to do fee for service to be trained as a doctor. I think that's where some people think it's part of the training.
Mhm.
That's not at all part of the training. Like literally you're going from a place of learning to, and yes, there's learning, see, they say pay for CME, whatever in big systems, but it's like you are going for your job of being a learner and being, what is it, a see one, do one, teach one environment to non-medical people are telling you that everyone has to have an A1C of 7.1 or you're not going to get paid. It's like,
Right.
what? That is not residency at all. So let me ask you there, because you were a person who, just like myself, had experienced fee for service and had experienced what you have just shared.
Mhm.
And you then saw this DPC. I don't know if you could share whose DPC you saw because
Sure. Yeah.
yeah.
Josh Umber's just up the street. He's 2 hours. Yeah, Josh, I contacted Josh. He's like, come on up to Wichita. I took a Friday. We had breakfast for an hour and a half, went to his clinic for about 3 hours. And I was like, had he offered me a contract that day, I would have signed it. I'm ready for this. And that was probably, a good 8 months before I actually, a few months before I resigned, about 8 months before I started my practice. But man, I saw that and it was puts on the floorboard. I'm going 100 miles an hour straight forward for DPC. I knew there was no other way. And I talk about this too, and it's funny. Not that I'm looking to be bought out by venture capital, because I'm not, but I have a close connection that's a venture capital guy, owns his own fund, has invested in some phenomenal companies that you would be familiar with even. But he and I sat down a few weeks ago and just talking through like my growth strategies and like what my goals are. And I told him there's an equation for going independent and going into DPC. There's a financial equation for that. And he said, "Oh yeah, what does that look like?" And I said, "It's net zero." And he goes, "Interesting." I said, "Think about this. Most residents or physicians, by the time they get out of residency, about 3 to 5 years later, they've acquired enough assets and have enough liabilities to equal net zero. And at that point, there's truly, other than potential wages, there's no actual risk, right? Guess what? If they jump into DPC and it doesn't work for them, which I think it will, but if it didn't work for them, they're out a year or two of their life, right? What have they actually lost? It's like when we talk about insurance, what are we insuring here? We've got people on insurance plans that are spending $10,000 a year. They don't even have $10,000 in assets, yet they're spending $10,000 in premiums. Why are we insuring that? Yeah, that's my equation for DPC. If anyone ever is looking at how do I know? If you're net zero, it's easy. If you're less than net zero, it's still pretty easy. You know, when there's more to risk, I guess there's more to lose. And I even think about that now. I'm almost 6 years into it. And I go, what if I had to make the change today? What would that look like? And given what I've built in even just those 5.5 years, now I feel like I'm risking something to make a big move. But at that time, not at all. The only thing I was going to lose at that point was more years of my life.
Yeah.
I'm sitting behind my desk in the old model with the hospital employer. I remember specifically thinking, I've been in practice 5 years. And if I do another 5 years like this, I'll have no professional growth. I'll be seeing the same people doing the same things, feeling the same way. I don't see an end to this. And I don't feel like even though I was pushing to grow professionally, I didn't really feel it. And I'm going, I know there are things going on in the world in healthcare that are innovative, new, changing, all of these various things. And I'm like, I don't even have a place in the conversation. I don't even know who's having the conversation or what those even look like. And to me, again, I even said this within the last week to a couple of my colleagues, I had no idea what I didn't know. I had no idea how small the box was that I was in. And the things I've learned, the people I've met, the things I've been able to do, and just the personal growth of getting into direct care and advocating for patients on such a different level, like absolutely life-changing.
It's incredible. And I hope that it's so inspiring. It's inspiring to me, but I hope it's so inspiring to the listeners too. What you spoke about with prevention, I feel in terms of that burnout prevention specifically, is not only paying attention to the finances. And I think that net zero definitely is a very awesome way to think about DPC, but it's also because you are at net zero, because you're doing direct care, you're able to be a dad. Like you're able to do things that you could not have done with the same presence if you had stayed in fee for service. So let me ask you there in terms of you opened, you said 8 months after, you had seen a DPC practice, and get thyself to a DPC practice if you have not. It is amazing. I have talked about my first time seeing Santa Cruz DPC, but it's just wow, this is real. It's not just, like voodoo medicine. Like there's an actual patient bed and a desk, and there's an EKG machine on a cart. And this is like a real clinic. It's amazing. And you can see it in people's pictures, but it's one thing to see it and it's one thing to be in a DPC. So get thyself to a DPC if you haven't. And if you have, just do it again for fun. So when you were transitioning, did you, because like you said, if you had been presented with a contract that day, you would have been like, I'm in, man. But you are a dad. You have 5 kids, correct?
Four.
You have 4 kids. That's still way more than the 2 that I can handle. So that's a lot. And you like you had a way of being an income earner, you had a way of being present in your family. How did you plan your transition to be able to open 8 months later?
So it actually, I had actually started and formed my LLC, gotten my documents ready before I had seen a DPC clinic. So I knew like, I'm going to be independent. What is this going to look like? And so I had already started on an initial pro forma the year before. And to be honest, the first pro forma I looked at was what if I just transitioned from employed to independent and stayed fee for service? And the numbers didn't look that great. It looked like a lot of work and the numbers didn't look that great. And I had a couple of colleagues that I talked to and said, hey, if I jump, are you willing to jump with me? And they couldn't do it at the time. And that's totally fine. I'm glad they didn't, and I'm glad we couldn't, because the extra time that bought me to say, okay, this isn't going to work. And by the way, I'm looking at this. This just isn't, what am I gaining here? And I wasn't gaining anything. The only thing I was gaining was more burnout, more work, and less pay. I'm like, oh, that doesn't look pretty. And so a lot of conversations with my colleagues. And I'll tell you, this is a really interesting thing. As I saw, read about, and really experienced DPC, I was invited to go over to my school, OSU Medical School in Tulsa, to talk about the evolution of osteopathic medicine. Okay, that was the topic of the day. But at the end of the time of talking to this group of students, one of the students raised her hand. And she said, I have two questions. Number one, how many patients do you see per day? And number two, do you feel like you have the adequate time to spend with your patients to give them your very best care? And I'm like, the
Super
first
smart.
question's really easy. I can tell you that one. But that second question haunts me every day. Like, you just hit me at the core of what bothers me. And it's funny because she came up after the meeting and she goes, hi, my name's McKenna Rickner. My dad is Kyle Rickner. He has a DPC clinic in Oklahoma City. I said, that's funny. I actually know who your dad is. And we haven't met yet, but yes. And she goes, here's his cell number, give him a call. And so yeah, I was on down the road of being independent before I even met Kyle. But yeah, we're good friends to this day. McKenna then, as a student, came and rotated with me at my clinic, and now she's finished residency and starting DPC like this month or next month. So pretty cool, small world too. But yeah, I thought, wow, what a direct question from a student who got it even as a second year medical student. She was already in tune with how do you provide the best care and are you doing that in your current capacity? I thought that was incredible.
Yeah, absolutely. And I think that this really speaks to it really matters. Kids coming from families who smoke, they're more likely to smoke. It's if you see an independent practice, you're gonna know it's out there and you're gonna see the differences between what we do and what we don't do because we're not fee for service doctors. So I think it's really important. And I think that is so awesome. I'm gonna reach out to the Rickners to get them on the podcast too, because I think that's so cool. The generational DPC. We see it in Dr. Kissy Blackwell's family as well. So I think this is awesome. Let me ask you about Oklahoma because
Sure.
being in Enid, you have multiple locations, but starting in Enid, tell us about the geography. Who lives there? How far are you from the airport? All of these things.
Sure. So Enid, funny enough, I grew up about an hour northwest of here in a small town called Alva, Oklahoma. They had a regional university there, about 6,000 people in the community. It's definitely a farming community. And then with the higher ed, with the regional university. And Enid to me represented the city, right? But it was more like 50,000 people. So it's 10 times the size, right? But I never saw myself actually living in Enid. In fact, the reason I ended up here was a $10 lunch that somebody bought me in medical school and said, hey, we're doing this residency in Enid. Will you guarantee me that you'll do a rotation? And I was like, sure, I'll do a rotation. I'm not going to go there, but sure. And a couple weeks into that rotation in Enid, I was just like, I need to be here. This is a community that it's my kind of people. It's definitely an ag, blue collar industry kind of community. Like I say, almost 60,000 people. We have an Air Force base here, so the Air Force is a big influence in our community. We do have a junior college and a branch of a regional university. We have, as I say, Enid doesn't have, I'm blank on what I call it now. There's no breaking point for Enid for me. Like all of my needs can be met here. We have three airports within 2 hours. So I can go to Wichita, Tulsa, or Oklahoma City. Makes shopping for the tickets a little more difficult because now you're looking at three different starting points, but you have a lot of options too on where you want to fly. And it's really almost equidistant to those three airports. So yeah, lots of farming. Our service area is about 150,000 people or a little bit more. So pretty good size. So yeah, the clinic started here in 2019 in January in Enid. And in November, actually over Thanksgiving break of 2018, one of my PA colleagues that was in the same health system gave me a call. And she said, "Hey, what is this thing you're doing? I've heard a little bit about it, but what is this? And by the way, I'm thinking about leaving, and I'm also a little concerned they may be closing my clinic, this rural clinic." So I don't really know what my future holds, but I'm curious, what is this? And so we had a 45-minute conversation. She calls me back the next day. She's like, I couldn't sleep. I can't stop thinking about this. What if I want to do this with you? I was like, we're 5 weeks away from opening. And she goes, I'd like to do this, but is there some way that I can do this independently? I don't want to be an employee again. And so that actually was the birth of our MSO, our management service organization, is that I said, let me make a few phone calls. I called a credentialer, my attorney, and CPA. And I said, is this a doable thing? How do we do it? And we put it together. She opened January 2nd, her doors 5 weeks later, the same time we did. And so essentially everything we had done, we piggybacked her, yet kept her independent in her own LLC. And so from there, we had that model of, hey, this works. So we're able to manage the administrative services together to her benefit, but she gets to keep a very generous portion of that. We're not taking much at all. And she's really happy with it. So here we are 5.5 years later. We were on the phone this morning, and she's in a community of about 1,300 people, has a panel size just under 500, with an FQHC 2 blocks from her. Pretty impressive. There's 3 providers 2 blocks away from her that have federal subsidy, and yet she's in a DPC model as a PA with that big of a panel. And that's substantial. So she was the first one to open. A year later, we opened one in Fairview, Oklahoma. It's a pretty small community as well, about 3,500 people. We have a DO and a nurse practitioner there. And then a year after that, we opened in Altus, Oklahoma, which is 3 hours from me. That was through word of mouth connection. I got a call from a nurse practitioner down there. She'd never been in independent practice. She'd also not been in that community. She'd been in a community about 30 minutes away. So I'm like, this feels somewhat risky, but I'm going to tell you everything. Incredibly transparent with my partners. They see everything. I tell them everything. And she wanted in really quickly. And I even told her, no, not yet. Like, you need to sleep on this. You need to be asking more questions. You need more information. And funny enough, the further we went, the more excited she got. She's like, I can't wait. I can't wait. So she is not even a year and a half into practice as a nurse practitioner, new to the community in terms of a provider, and she's got just under 400 patients. And it's incredible. She's very hungry, I will tell you that. And that what I love about the model that we do with the MSO is that we allow the independence factor. And when you're independent and you're not employed, you're hungry. This has to work. And so we're like the backbone of making it, helping it work for them, and consulting with them along the way, helping them not spend money where they don't need to, making decisions that could really hurt them. That is really the value we bring, and they get to be independent and have the benefits of that as well. We really enjoy it. Plus, I'm not managing all of the employees and managing all the providers as employees. We're really partnering together to just grow our practices.
And when you have skin in the game, it definitely makes you act on a team differently. And that's definitely something that a lot of people are thinking about as they get their number of patients and they're like, oh, I'm starting to sense that I need to expand either options for people to see other people within my clinic or branching out to open a new clinic. Recently, I had a conversation with Dr. Ben Aiken. We both know him very well, but I wanted to ask, because as you're talking about even having a clinic 3 hours away, one of the things that we talked about, Dr. Aiken and I, was this idea of the Cheers effect. And so he describes it as the sitcom Cheers, where you go in and everyone's like, Norm, and you get the same culture every single time you walked into Cheers. How do you maintain your culture with different people in different locations, but also do you like when you talk about independent practice, I don't know in Oklahoma, are the non-physician providers, APs, excuse me, PAs and nurse practitioners doing completely independent practice in addition to being independent in location? Those are the questions that come up after you just sharing what you did.
Sure, yes. In the state of Oklahoma currently, our PAs and nurse practitioners have to have a collaborating physician. They can have their own LLCs, they can have their own practices per se, but they do have to collaborate. Specific to the PAs, they have to have a collaborating physician. Under the NP law, essentially, they have to have a collaborating physician for prescriptive authority. So really, they have independent practice. They just can't prescribe without a collaborating physician. And there's a wide variance on what supervision or collaboration looks like. In fact, we from the physician side say we're not doing a good enough job of defining that. That's part of our problem. And there's too many people who are either taking advantage of mid-levels through those arrangements, or what I believe is a worst case is the hospitals are assigning physicians to collaborate with people that they didn't choose, they don't know, don't have a strong connection with, and they're really not compensating them well for that. And so those relationships just don't develop like independent relationships would. Like under how we do it, I don't charge my mid-levels any supervision fee. It's just we're working together. Like you need us, and that's the relationship. You need us, we have a business relationship together, and you need to be able to call me at any point in time. And the benefit for me is that you're in business with me, right? But I don't like to do that on the outside of my business, right? That would be a different, more difficult sell.
Absolutely. And in terms of maintaining the culture, with everyone having skin in the game, how do you also maintain the culture that if a patient goes to Enid, if a patient goes to Cherokee, they're experiencing Reliant DPC the same in terms of like how they're treated as patients, how follow-up goes, how the quality of care goes?
It's a good question to ask, but the funny answer to that is that I don't. Okay. So I don't oversee specifically those clinics and how they treat their patients. I actually don't want to. But in terms of the culture is we're going to train you how to, in terms of the way we conduct business, the stuff we have to give to our patients to provide the very best experience. And so part of it is just giving them that backbone of here's what you need to provide that experience. Now just go do it. But we're not going to tell you exactly what you have to do to provide that. And ultimately, as you've seen probably, the absolute vast majority of our colleagues in DPC become they become their best. They literally become their very best provider, because all those barriers that may have drugged them down, whether that was a time crunch, time barrier, resources barrier, whatever that may have been, when we've eliminated those, it's like you literally get the best out of people. And I've seen, and you should absolutely, I think you've met him, but one of my colleagues here locally, Dr. Jansen, he literally stepped away from medical practice, literally stepped out at 36 years old or whatever, and said, I can't do this. And took his own leave, his own time, and just said, I don't know what I'm doing from here. And to see where he was 2 years ago, just this absolutely beaten down fragment of himself, and to then sit next to him in clinic every day and see the smiles and to hear him so excited about what he was able to do for a patient, all of these various things, I'm like, that's the magic of what we're doing. Because I've taken him in that position where he was, and I had empathy for that because I had been there. But then to see him thriving is absolutely incredible. I love it. And he tells his story really well as well, but just incredible transformation. And so to go back to your question, what am I doing to create that? I don't want to take too much credit for it. So all I'm doing is I'm putting myself at the front of it, leading, encouraging, being available, and just continuing to promote my colleagues as individuals and just allowing them to just practice.
It's something that I think about literally, not only just talking with Dr. Aiken, talking with you, talking with other DPC doctors, but like every time I go through Dutch Brothers coffee, I'm like, How do they get so on point with hiring people who are peppy and quick and they will tell each other, hey, if there's an adjustment that needs to be made in the drive-through? I'm like, how do they do it? I literally have Googled the heck out of what is the hiring process. So shout out to anybody whose son, daughter, neighbor has worked at Dutch Brothers. Tell them to leave a voicemail and I will contact them because I would love to just even hear a little bit about how it works. You usually get an employee hired typically in 6 months, and their turnaround is like within a month. And the fact that Dr. Jansen went from medicine to not medicine to back to medicine and is still doing DPC at Enid with you, it's incredible. And I think that it gives people especially hope if they're on that I can't do this anymore wheel. So amazing. Now, and I think that's a great answer too for people to hear like how your culture is at Reliant, because it's like clearly you guys are growing. Clearly people in the community are like, this culture works for me because it's way better than what I had before. There is no magic answer. And if you've seen one DPC, you've seen one DPC. So the way that your patients are signing up for Reliant DPC, you can go on to sign up at our practice, press the button, start putting in your information. And I want to ask in terms of, it's a great strategy to lower the barriers to signing up, but have you seen it lead to any form of churn because a patient is just signing up? Or do you have on the back end like a meet and greet or something required to really not only get the patient signed up in terms of their demographics, but also to make sure that they're a good fit for the practice, especially the location that of Reliant DPC that they're going to be going to?
Great question. Yes, we have the sign up links, we have the online links, even some Facebook push buttons. But I'll be honest, the majority of ours, I would say 80-90% of them have called the office, have asked a lot of questions, had that conversation. We offer, for those that are just on the fence or not really sure about it, we offer those meet and greets. Just come on in, meet Dr. So-and-so or meet them, see what you think. I'll tell you, in these smaller communities, if you went into like Cherokee or Fairview, that's pretty well always taken care of. They already know them. They know them from the community. They've been around the community. And in many cases here in Enid, it's still that way. We're different from a metropolitan area. There's literally, at this point, I've been in Enid for almost 15 years. I don't go to church, the grocery store, the convenience store. I don't go anywhere without seeing somebody I know. Whether they're a patient, a former patient, a patient's family, you name it, there's connections everywhere. And so word of mouth is our definite biggest factor in marketing. And we kind of challenge patients to give it a try. Come in. If it doesn't work for you, that's fine. If it doesn't work for us, that's fine. It's very rare we've ever turned a patient down because it didn't work for us. Incredibly rare. And I can't even think of a case of that. But it's really cool when a patient comes in. And we talked about this. Ben was up in DC with me at the Primary Care for America. And we talked about this on stage with Dr. Pastor and with Mark Tomasillo, Jeff Davenport, and then we had a representative from Boeing as well. And in that panel discussion, what we really focused on and what we were trying to drive home was that direct primary care has redefined the healthcare experience, right? And that's what our motto here as well is, we're redefining that healthcare experience. My dad, this is great. I took a trip out of state. It was a lot, like 18 hours to and from to go pick up some stuff for my family. And we did this last weekend. And he was mentioning a mutual contact that we have that drives an hour and 15 minutes to our clinic one way. And this gentleman's 86 years old. And he goes, oh, he's a conservative guy. I guess I'm a little surprised that he does that he comes. He goes, I guess it's just the fact that you take more time and he's more of a human too. I guess that's really what it is just the ability to get in when you need it, have somebody you know that gives you the care that you feel like you deserve, rather than just getting a little fragment of time and not even getting your questions answered. And my dad's actually a DPC member as well. He sees one of my colleagues here, and he's had the same experience. This is totally different. My uncle, same way. I've never had care like this. It's been 30 years since I've walked into an office and had that kind of personalized care and felt like they had time enough to take care of me. And so we really are, I think, as a whole, the ecosystem of direct primary care is redefining the healthcare experience. I think that's the message we got to drive to employers, and we got to drive to decision makers, policy makers, is that's what we're doing. And whether we represent 5% of the patients in the world, 10% of the patients in the world, whatever, that's where this is going to become mainstream, is where patients as a whole expect this experience. And they're turning to the health systems, they're turning to the insurance companies, they're turning to their employers, and they're saying, I want that. Why don't I get that? It's affordable. Like, why is that not built into my health plan? Or why is this not built into our hospital health plan? Like,
Absolutely.
we work for the hospital, yet we can't even get this kind of care from our own fellow employed physicians. I want something different.
It's sad and laughable sometimes that it's like you work for the healthcare system. It's like I remember when I was in residency, I was at a for-profit hospital, but one of the things in our contract was like, if you need your surgery, which I did when I needed my gallbladder out, everything's covered. Like, it was like I knew the surgeon, I was able to talk with them, but that is not the standard experience that people have when even they work for the healthcare system and their insurance comes from the healthcare system and they still can't get access to care. And I will say here too, because this is a perfect bridge to talking about your role as an advisor and also working with employers. But I will say that what you are speaking to, that patients want this, it is so important. Literally, just before we got on the recording, I have two people who I was talking with, and they're asking their employer and having talks with their employer to, could we have this? Could you get us this? Because this is like really inexpensive. Just like you said, it's affordable. And it's like we could not have to take off time to go talk to a physician or non-physician provider about a rash. Like, literally, we could like text our doctor. Like, that's amazing. And I got a text literally before our call saying, hey, we're signing up. The employer's on board. And it is literally a game changer when you have people who are, it's just, I encourage people, medical students and residents all the time, to go out and ask their residency programs and stuff to have presence of DPC in their didactics. But it's the same thing with patients. And this is why word of mouth is so amazing, because you're like, oh my gosh, you want something that you can't have because of what? There's no barrier except you haven't asked for it. So it's incredible. So with that, as we talk about patients and access, a huge portion of our culture in America that is asking for and frankly demanding for change in healthcare and how it's delivered is the employer space. Now, this is very time appropriate because we're about a month away from Rosetta Fest, which is the Health Rosetta conference or summit that is very centered around direct primary care, direct care, and delivering direct care to employees through their employers. What is Health Rosetta in your words? Because a lot of people still are not even aware of Health Rosetta. And then we'll start talking about your role as a Health Rosetta advisor and a physician.
Yeah. Health Rosetta is essentially just a network of independent advisors around the country that have adopted the principles of the free market, adopted the principles of transparency, full disclosure, and are utilizing, we'll say, newer forms of models, whether that's payment models or care delivery models, to provide the very best care, the best price, best quality. In a nutshell, that's what we're doing. And there are groups, there are dozens of advisors that work together. And then there's groups of independent advisors on their own. And so it looks very different. They come from all different aspects of backgrounds of life. Some of them came from big benefits consulting firms and went out on their own. Some have started their own. So it's a very mixed bag of people, but they all share very similar passions about, hey, there are fixes in this healthcare system. Healthcare is local, and let's bring it back local as best we can. It's funny about the Health Rosetta. About 5 years ago, I was 6 months into practice. I was seeing this stuff about Health Rosetta. I was reading Dave Chase's book. I'm trying to figure out, I don't get this. And I'm not the most intelligent guy, but most things I pick up on fairly quickly. And I'm reading through this going, I don't get this. I don't understand this. What is this? And so I scheduled a call. I reached out via email to Dave and I said, hey, I want to know what you're doing. I'm a direct care physician. I'm really curious about what it is that you're doing. He said, let me connect you with Amy Levrier and Sean Shanson. Okay. So I get on a call with them, and Sean, if you've ever met Sean, he's an attorney. He's just real straight. Here's what it is. He just laid it out. But I remember he said something to me, and I hadn't thought about this until you asked the question. I haven't thought about this in a long time. But he said, think about it in terms of economics. Your primary care, you're microeconomics. We're Health Rosetta, we're macroeconomics. You're on the ground, we're at 30,000 feet. Still didn't completely make sense at the time when he told me that, but funny enough, I'm in a group of, I went to sponsored a SHRM breakfast, human resources managers, breakfast with the bosses, an annual event here locally. So I had literally like a bunch of companies, owners, CFOs, HR directors, all in the room last week. And right before, they gave me like 5 minutes to introduce DPC to them. And some of them already participate, some of them I've talked to, some of them, haven't. And I'm thinking 5 minutes. But I allowed my colleagues to introduce themselves. There went some of my time. And what's funny is one of them was like, 5 minutes isn't even close to adequate to explain what we do. But let me just tell you, it's the best thing I've ever experienced as a clinician, and our patients love it. And so I was like, oh, that's a great way. So it came to me and I was like, so I agree, it's really difficult, but let me explain what I feel like is we are healthcare from the ground up. Primary care is that first point of entry where patients are coming in and trying to figure out, number one, what's wrong with them, where do I go, what do I do, how do I get the care that I need? And so we are that ground level, and we're trying to work them their way up. And then I introduced to this group, for those who didn't know already, to this group as well, is I've become a licensed advisor. I'm actually working directly for employers. And I was like, just like primary care is the bottom up, think of me as an advisor as the top down. And the marriage of those two, especially if you understand the language of business owners and you understand a little bit about taxes and a little bit about finances and a little bit about human resources and employee management, et cetera, you're able to marry those concepts and ideas and say, I'm advising you like other people do, but guess what? I'm coming at you with the background of clinical medicine and understanding what this looks like face to face, patient to patient, day in, day out. And that right there is that's a value that I can assure you isn't existing in your current health plan portfolio or advisor group. It doesn't exist.
It doesn't. And I think that there might be some people in the audience who are like, wait a minute, that sounds really cool, but what does that even mean? So I want to ask you, in terms of putting it in a context, because you are able to see, literally, you're able to see the bird's eye view. You're able to see it from the ground. You're able to see it from the air. When you are educated to be able to see everything, and you're also the one delivering the care, and you know what quality primary care means in terms of prevention and in terms of relationship building. Could you give us an example of how those two roles have come together for an employer and their employees?
Sure. Just to take your first kind of observation or question back again, is what is an advisor doing, or an insurance broker? Most people would think of it like that. I like the term advisor. It doesn't feel the same. But an advisor to the health plan is literally looking at what the employer-sponsored health plan is. And under the Department of Labor, there's, of course, federal laws of how that's regulated, a lot of insurance regulations. For me, honestly, my first job at 18 years old was filing claims for a neurosurgical clinic. So I've been seeing claims, HCFA 1500 forms and EOBs and auditing EOBs, and I've seen all this stuff for so long that it wasn't a new language per se for me. So I did have that advantage. Plus, I was a political science major, and my capstone paper as a senior was the rising cost of healthcare. I've had my head wrapped around this for quite some time. But then clinically, where I got really interested in this is that it's twofold. One was I was really struggling to get our largest broker group, who had a lot of employers locally. The employers were very interested in direct care, but the conversations were ending when they went to the broker, because the broker had no incentive to do it. It was additional work. And guess what? Sounds terrible, but if they reduce the cost of the plan for the group, they actually are going to get a pay cut. That's just the way it's set up. And so those, what we call misaligned incentives, were so apparent. And despite years of worth trying to work with them, it was like, guess what, guys? I like you. You're good people. That's fine. You do your business this way, but this isn't going to work. Like, we're not able to collaborate very well. And so that was the trigger for me to jump into that. But I will say, when we meet with employers and when I sit down with an employer, whether or a CFO or an HR director, the decision maker in this group, the analogy to an initial primary care visit, it's the same thing. It's different language, slightly different questions, but it's the same approach. Because I'm going in and saying, hey, we're getting a little, get to know you. Tell me a few things about your business, a few things about yourself. Let's get to know each other a little bit. And I'm gonna start diving into questions like, what do you guys find to be one of the sticky points in your health plan? What bothers you? What's your chief complaint if you had one, right? Tell me about that. To some, it's the rising cost and they don't see an end to it. To some, it's access. I just don't feel like our employees have access. We spend $30,000 a month on premiums, yet my employees are coming into my office saying that they can't get into a primary care. Okay, well, that's your problem. But rather than, and you'll see this in DPC marketing as well, forget trying to tell people what you do in direct care. Just ask them questions. Let them tell you what their experiences in healthcare have been, and they'll tell you what you need to tell them. They'll tell you what they're looking to hear, which is, oh, so you're frustrated with access. Let me tell you what we have for that. Yeah, it's a pretty simple principle in marketing, is just to have to figure out, where is this person coming from? Meet them where they are, because it doesn't matter how cool your clinic is or how great a health plan you might have put together. It doesn't matter. You need to know what's going on in their lives and in their employees' lives. And as an employer, you need to know where they're at. And so that, to me, is why it's so easy. But I can't discount the fact that for 20 years I've paid attention to this stuff. And I guess I had a leg up on that, just knowing the problems and having researched them and taken an interest in them for so many years.
Yeah. It makes me think about how it is so empowering to know what's out there, just to know that DPC's out there is a tool to have in your tool belt, even if you choose not to do DPC or DPC is not for you today. But it's like, knowing about the employer space, I think, is so powerful in case somebody comes on your doorstep and they're like, hey, we're a new person in town. We have 50 employees and we would like to know more. And you're like, oh my God, I didn't prepare for this. That's an uncomfortable feeling. But I want to ask about, there are some in the DPC movement who, when they hear the word employer, the reaction is, I'm going to lose my autonomy. I'm going to have to do what the employer says. I'm going to have to take their rates. How would you respond to those people who are not necessarily in the know when it comes to everything that you're experiencing as an advisor? They're maybe open to it, but they're under the assumption right now that like I just mentioned, that employer equals loss of autonomy in my practice.
I actually don't feel like I've lost any autonomy in my practice working with employers at all. But I think there's a couple of really important foundational ideas around working with employers that, I'll be honest, one of them took me 2 years and I was really embarrassed. I had to go back to employers and actually say, can we talk about this again? Because there's been some changes to my practice, okay? And that was the way to get back in with them. But the change to my practice was actually the change to my marketing. And the change to my marketing was this: I was going in all or nothing. Oh, you've got 50 employees? Okay, here's what it would look like for 50 employees. And it was an all or nothing approach. And I look back and I go, why did I do that? But to the employers, they're thinking that way too. Most of them are thinking an all or nothing, right? Even the broker that struggled to work with, he thought it was an all or nothing. And I'm like, okay, so start small, think simple, okay? Your rates are your rates, period. If you're embarrassed about them, you have a problem, okay? But your rates are your rates. And for us, we have a corporate rate, we have a retail rate, okay? Whether you have 200 employees or 20 employees, the corporate rate is X. That's just the way it is. And it's not that we have this hard and fast, I'm a non-negotiable, like it has to be my way. Here's what it is. I don't want to create a disparity between your population and another population. I've been there before. Fee-for-service was that way. You talk to anybody in fee-for-service who takes Medicare and takes Medicaid and takes Blue Cross and Cigna and United and all these various different things. If they're looking at their schedule and they realize I've got an undue amount of X, Y, or Z patients, like I'm not getting reimbursed very well on those, like I feel like I'm taking a loss on those. We do not want to create that same sort of a disparity within DPC. I don't want to think of an employee of company X as being less valuable to me than an employee from company Y or Z. Don't do that to yourself. The other thing is our corporate rates start at 5 employees. People do different things, but that's just what we chose. Hey, you got 5 employees or more, you get the corporate rate. Okay, so there's a little volume discount. But the fact of the matter is, if you have 100 employees and only 5 of them choose to be a part of the DPC plan, that's fine. It's equitable. And that's the term I use with employers. It's equitable. Do not think of it as 100% because 100% of your people will not do this. Like, you will not be able to convince them to either go see a doctor or change the doctor. That's fine. But for those that we can affect, we'll affect them. And so one of our larger employers, within the first 6 months, we had 60% signed up. It was incredible, high utilization. Now, I will say that was 6 months in. Here we are 3 years plus with that same employer. There's really not a huge difference. Those that adopted it, and there hasn't been a huge difference. For others, we expect 25% in the first year, and that's fine. I had an employer call me a couple of years ago and said, hey, we've got 90 employees. How much would it cost if we brought them all onto your plan? And I said, I'm not going to answer your question. And he goes, okay. I said, I'm not going to answer your question because I won't allow you to pay for 90 of them. I'll only allow you to pay for those that come and establish care with us. And he hadn't thought about that. And as soon as I explained, I could take your money year one and you'll never do business with me in the future because you realize it was way too expensive for what you got, or we can do business the right way from day one and we'll be business partners for years. And that's exactly where we're at. We're business partners for years now. Those are the two foundational things. It's not an all or nothing. Keep it equitable and be fair. Just be fair and keep your rates the same. Don't discount your rates just because someone has more people. Every one of those persons are valuable, just like the next one.
Yeah. And this is where I've mentioned this on the podcast before, but especially if you've been to Health Rosetta, about what's happened in Ashtabula, Ohio, in the school district where the teachers, where it's the third poorest district in all of Ohio, school district, I should say, is getting CEO level care because they can and they should, and every American should and deserves it. And this is a way that they can do it affordably. And especially when the cost of plans is going up, and even if you are in a year where your employees were totally healthy, like, why is my cost of healthcare going up and I'm not getting any refund from the care, even though we didn't even utilize the insurance? So it's a great time to be educated. It's a great time to be involved. It's a great time to be in DPC. And it's definitely an option that is open to pretty much anybody in any community. I'm freaking rural, and I had 2 people just before this call who are like, hey, my employer wants to do this. It is a great time to know more. So I will put in a plug here. If you want to know more about Rosetta Fest, where you'll meet people like Dr. Bushman, people who are also physicians, who are also advisors, and just talking with advisors who are also in the Health Rosetta program, go to Rosetta Fest. It's going to be in DC this September. And I will also put a shout out here that the day before Rosetta Fest starts, we are lobbying in DC for DPC, basically sharing our stories. And every single one of you is invited to partake in that. You do not have to be part of the DPC coalition to partake. So that's a wrap for today's episode. I will be talking with Dr. Bushman more about the details of how he works with employers after those initial questions of discovery of DPC, and also how, after being open for years, he has taken the time to stop and reevaluate his clinic to make sure, that it is growth proof, which I absolutely love. And I think it's very pertinent to people who are wanting to grow their DPC, and more details about the MSO that he mentioned earlier. So definitely join us for the conversation over on the Patreon community. Thank you so much for listening. And thank you so much, Dr. Bushman, for joining us today.
Absolutely. Thanks again for having me.
Thank you for joining us for another episode of My DPC Story, highlighting the physician experience in the world of direct primary care. I hope you found today's conversation insightful and inspiring. If you want to dive deeper into the direct primary care movement, consider joining our My DPC Story Patreon community. Here, you'll have access to exclusive content, including more interview topics and much more. Don't forget to subscribe to My DPC Story on your podcast feed and follow us on social media as well. If you're able, I'd greatly appreciate if you could leave us a review. It helps others to find the podcast. Until next time, stay informed, stay healthy, and keep advocating for DPC. Read more about DPC news on the daily at dpcnews.com. Until next week, this is Maryal Concepcion.